Welcome to ProScan's Image-Based Neurodiagnosis seminar, which we'll be holding in our ProScan Theater on May 17th to May 20th. I think you'll see a new approach to education where my partner and I, Dr. Malcolm Shupeck, a Mayo-trained neurosurgeon, and myself, Steve Pomeranz, a neuroradiologist, will not only look at cases on slides, but we'll do case reviews and interact didactically a clinician with a strong neuroimaging background and a neuroimager working together to present you with the best information. We're going to show you an example of how we're going to approach an individual case, although this is just one small vignette of what you're going to see. Let's take the entity of Arnold-Chiari Malformation. Before you consider a diagnosis of Arnold-Chiari Malformation, some of the findings have to be taken into account on an MRI and sometimes a CT, including a small posterior fossa, which is one of the hallmarks of the disease, clival abnormalities, craniocervical junction abnormalities, intracranial hypertension, masses, hydrocephalus, sagging of the optic chiasm, and empty sella. Intracranial hypotension may be manifest as large dural sinuses that expand because the intracranial pressure is lowered sometimes after the surgical procedure of decompression. A large pituitary gland may arise after the patients have been decompressed, and a slumping brain stem. Here we see an example of a patient that has had an occipital decompression with the cerebellar tonsils extending downward and slight folding of the lower aspect of the medulla. Yet this patient who's been treated still has headaches. What are some of the possibilities that could explain this patient's persistent symptomatology?
Well, I think that there's one diagnosis that may be considered and is actually very poorly understood by radiologists, but also by some of the surgeons doing these procedures, and that is cerebellar ptosis. There's actually an excellent article in the Journal of Neurosurgery, January 2001, that is by Dr. Batzdorf and Dr. Holly at UCLA that describes that entity. Basically, can be an over vigorous decompression where the craniectomy is taken up above the equator of the cerebellum, and then the cerebellum will drop down and it recreates the obstruction to CSF flow. And that would be a reason for a Syrinx, which may have been the reason that the operation was done in the first place, may reoccur.
So over-vigorous surgical correction of the problem can be a problem unto itself and maybe even harder to correct than the original problem. Let's move on for a moment. There's some confusion about Arnold-Chiari malformation and this entity of cerebellar tonsillar ectopia. The level of descent, in other words, where the tonsils sit relative to a line drawn from the basion to the epistheon, really matters. Variant ectopia is considered when you have the tonsils about 2 to 3 millimeters below this line without any of the other secondary signs of Chiari. Mild, perhaps one tonsil with 3 millimeters of displacement. Moderate, one tonsil, 5 millimeters of displacement. Marked, 3 to 5 millimeters of both tonsillars being displaced. And severe, greater than 5 millimeters, both tonsils being displaced. Now, you see we have a quick discussion of secondary signs, but around the country, there is quite a bit of controversy about over-vigorous or aggressive decompression in young children for ectopia and Chiari malformation. Do you have any comments on that, Dr. Shupeck?
Yes, Steve. I think the first point is correction of a Chiari malformation is a big surgery. Incision going from the inion to the mid-cervical spine, cervical laminectomy, suboccipital craniectomy, intradural dissection, and reconstruction. And with a surgery like that, there can be substantial morbidity, or at least potential morbidity. CSF leaks, pseudomeningoceles, most common, but even vascular injuries. So you really have to select the patients very well to justify the potential for that morbidity. Now, I think that it is hard to select because, as you just mentioned, there's a lot of variation in the appearance of people's tonsils. At the same time, there's a big population of people who have headaches. So those two populations are going to coincide without really a causal relationship. So there is a doctrine that that is used in Europe more than in the United States, saying that a syrinx, the presence of syringomyelia as a consequence of the Chiari, is really the only indication for decompression. That may be a little too strict. Okay, there probably are people with very stereotyped types of headaches or cranial nerve abnormalities that may benefit. But if you're going to think about operating on someone who does not have a syrinx, you really need to very carefully analyze that clinical situation.
What tips you off as a clinician to the diagnosis of a syrinx before you ever look at the scan?
Patient with a syrinx is going to have neurologic findings, and basically a syrinx is going to be a cyst in the center of the spinal cord that forms, and there's a number of theories as to how the Chiari creates it, but probably hemodynamically or hydrodynamically, sorry, to create the syrinx. And so you're going to get symptoms of central cord syndrome. Central cord syndrome is going, since the fibers going to the upper extremities are closer to the center of the spinal cord than those at the periphery, you're going to get symptoms in the arms and hands first. Hand numbness, hand weakness, clumsiness, and then later gait disturbance, hyperreflexia, other signs of myelopathy.
Thanks. That's very, very helpful for a non-clinician. Now, normally, the tonsils do have some age-related changes in descent below a line drawn from the opistheon to the basion, which basically defines the foramen magnum. In the first decade, the tonsils are pretty low. They can be as much as 6 millimeters displaced. And this is most pronounced at 4 years, and then they retreat. So if you see a young individual in the first year of life with low-lying tonsils, that is not an indication that somebody has tonsillar ectopia or needs an operation. And then you see the progressive ascent that occurs throughout a lifetime, eventually resting at about 3 millimeters in adulthood, and you can read through this ascent on the given information. The clinical profile in patients with Chiari malformation can be very nonspecific, from something as simple as a headache, as Dr. Shupeck has mentioned, to something that is more specific or more revealing, such as rotatory nystagmus. The patients who are very young, approximately 3 years of age, they may have difficulty swallowing, which is something as radiologists, as imagers, we don't think about. Children, average age mean 11. Headache is a common symptom. Neck pain, syrinx, of which you've heard some of the symptoms, progressive scoliosis. And then the adult, mean age 34. Neck pain, drop attacks, which is something we don't associate very commonly with Chiari malformation. It seems that children respond better to treatment than adults, and perhaps you're just dealing with better tissues, but I'll let the expert address that specific issue. And the male to female ratio is almost equal. It's a little more common in women than it is in men. Now we'll just finish with a couple of other salient points. Tonsillar impaction can occur without herniation and can be symptomatic. In other words, you can impact a tonsil that hasn't descended, that is simply packed into too tight a posterior fossa. As mentioned, an international discussion has arisen that's controversial, and that is that patients with Arnold-Chiari 1 malformations without syrinxes should not be operated on. And these are the types of things we're going to be discussing with a clinical expert and with a neuroimager in our course. And finally, beware of the overzealous decompressors and overzealous decompressions, the so-called cerebellar ptosis phenomenon, which Dr. Shupeck discussed earlier. And these are going to be things that we drill into to try and limit the risk to the patient, the exposure to the imager and to their clinician, using a combination of the science, some common sense, the imaging, and a very experienced neurosurgeon. I hope to see you in Cincinnati on May 17th, where the sun will be shining, the Reds will be playing, and we'll be very interested in education. Bye-bye.